We're going to get back underway. So to our live crew, if you don't mind, we'll get back underway. And to everyone at home, welcome to the next session. So I'll invite our live crew to filter in quietly. Welcome to Session 2, Lifestyle Breakthrough Program with Dr. Kevin Lee. Thanks to the Grampian Weight Specialist Clinic for sponsoring this session. And remember to pop over to the sponsors or browse through the individual pages, both virtually or live here in Geelong. And please take note of the health pathways for this session on the screen at the moment. And you may also download this from the resources section. So if you have a question for Dr. Lee, please type your question in the live Q&A box on the app or online portal. I think that's working quite well now. Don't forget to upvote questions. And we'll just have as many questions as we can. For any general comments, and I noticed last time a lot of people were using the Q&A for the poll or comments, pop them in the discussion board. I mean, it's not a big deal, but that just keeps everything quite orderly for us. So I'd now like to welcome Dr. Lee. Dr. Kevin Lee is a consultant endocrinologist and researcher at Monash University. He leads the Grampians Weight Specialist Clinic with its weight specialists, whom he mentors, and an allied health team. So his PhD and ongoing research is in stress and its impacts on metabolism, and it's translated to improve patient care. He's received awards and grants from the Endocrine Society of Australia, Diabetes Australia, and Royal College of Physicians for this work. So thank you and welcome.
Thank you, Bianca. I thought I'd actually start by talking about a case that I saw just this week, given the talk that preceded mine. She's a 68-year-old lady that had binge eating disorder, but had a BMI of 60, and she struggled a bit reconciling what she was being told by her psychologist and dietitian in terms of not measuring her weight, being healthy at every size. And I agreed with her that healthy at every size is a very important philosophy. However, to measure one's weight is also one of the many indicators of well-being, and that she should at least know where she's going. Now, for a long time, she sort of didn't feel comfortable with knowing her weight, but over time, she went from 160 to 180 kilos, and by that time, she was already not being able to move easily. She needed a walker because her arthritis was getting really bad. She had really bad lymphedema. And so with the help of the psychologist and dietitian, we actually use a healthy at every size philosophy along with a healthy nutritional sort of balanced way of eating and also liraglutide. And I know they were reeling a bit, the dietitians and psychologists initially when you use liraglutide, because that's looking at weight loss. But now she's being able to enjoy her meals and her weight's come down to 140. So losing 40 kilos made a world of a difference for her mobility. And she is actually not sort of fluctuating between being extremely restrictive and then binging and purging later. So I think that the philosophies can actually coexist. In fact, they must. And that there shouldn't be that sort of dichotomous type thinking when it comes to losing weight, but also maintaining a very healthy eating pattern. So with that case in mind, I'd like to start by talking about the weight issue and how we are looking at it as patients come to us with their various metabolic syndrome issues. So I'd like to give a practical sort of day-to-day approach to weight loss, and this is based on an integrated biopsychosocial model. I have support from industry and government, and the most recent funds that I got was from the Foundation of Rural and Regional Renewal, which allowed me to set up a social prescribing setup, which I'd like to have a discussion around later. So I'd like to start by talking about what the obesity epidemic actually is. So if we go back one slide. So 2 out of 3 Australians are actually overweight or obese. It means that if your weight is normal, you're in the minority. And what's actually worrying is that the rate of obesity, so we're not talking about the number of people that are obese, we're talking about the rate. if you're born in the 70s, your rate is 7.2. If you're born in the 90s, your rate is 16.5. That rate is increasing. Now, we have a lot of people that have very simplistic ideas that the environment, the obesogenic environment, is all that's causing this. But, a sedentary lifestyle was not dissimilar in the 70s as in the 90s. We had cars, we had escalators, we had, desk jobs, etc. And there are sort of also hidden sugars that were in our foods since the 60s. The food industry already started doing that. So there is something happening. And the etiology is actually far more complex than sort of simplistic sort of understandings that a lot of people prescribe, which is just telling our patients to eat less and move more. Now, if that was really the solution, the obese population should not exist. So why are we interested in obesity? Well, we don't take an interest in weight just because people want to look good, because it actually comes with lots of other comorbidities. And in fact, I'd say the current guidelines are perhaps inadequate in actually dealing with the ethnic population that Australia is today. In this graph, you'll see here on the x-axis is actually the BMI, and on the y-axis are the incidence of type 2 diabetes. The point of inflection, you can see there for the white population, is a BMI of 30. That's when you start to see a climb in the rates of diabetes. But if you look at other populations, like the Chinese, South Asians, you'll see that that point of inflection is much, much lower. So many of our ethnic groups actually need a lower BMI. But the current guidelines for even you being allowed to prescribe anti-obesity medication is usually over 30. And I think that's a bit Anglo-centric. So why is dieting and exercise alone not good enough? Well, this is a meta-analysis of lots of different studies looking at all the different ways in which people can lose weight from dieting and exercise alone. And you'll see,
Just have a look on the screen and it'll tell you which one you're up to.
oh, which one I'm up to?
The laptop is running, just
Well, it's a bit slower. That's why the lag is, yeah. All right,
orientating.
cool.
But that's, yeah,
There we go. All right. I'll look at the screen actually. So you'll see that with most interventions, you can lose weight. So a lot of your patients, when you ask them to eat less and move more, yes, they will lose weight. You can use any sort of diet you like. You can use 16-8, you can use ketogenic, you can tell them to count calories. It all works, the bottom line is. But what doesn't work is that it doesn't allow you to maintain that weight loss beyond a year. In fact, the Finns, with their meticulous records, have actually these twin studies that show that identical twins living in the same environment, the more times one twin diets compared to the other, you have a BMI difference of 1 point by the time they're age 25. Yeah, so dieting is perhaps not the long-term solution for patients. Dieting is useful, especially if you have a patient about to go for surgery and the surgeon needs to have access for keyhole surgery and you want them to succeed well for surgery. But long term, you can see that most interventions cause weight regain beyond a year. And these days, we don't even look at studies that don't have data beyond a year. I'm going to run through just some quick studies that inform us of etiology. And you can make up your mind as to how each factor contributes to the obesity epidemic. A lot of people like to sort of think that it's either the environment or their genes, and they sort of are in one camp or the other. But in reality, it's actually a mixture of both. There are twin studies done early on that showed that monozygotic twins if you raise them together, and you also, unfortunately, there were some twins, identical twins that were raised apart, the correlation coefficient of their weights were not dissimilar, they were 0.7. So you can see that there is a strong genetic component as to how closely weight is regulated. Another interesting study is that if you think that it's just all genes, well, what about looking at the difference in rates of obesity between China and Japan? You know, Japan has an obesity rate around 3% or so, whereas China, it's about 15%. Yeah, so I'm not saying that genetically they're the same, but they're not dissimilar. You just have a strait separating both countries. Another really interesting thing is about epigenetics. So we know that during World War II, when the Nazis were blockading food entering Holland, children born of women during that time were more likely to be diabetic and overweight compared to their siblings not born of that time. And from there, the study of epigenetics has started. And I think epigenetic change is something that contributes a lot to what that difference in incidence you're seeing is. And lastly, stress has a very big impact on weight as well. It actually has a bidirectional effect, and I'll talk more about this because this was my PhD. And one of the big studies that was quite useful if you want to understand it are the Whitehall studies. These are, so Whitehall is like the administrative arm of the UK government, and they could do GTTs on tens of thousands of the employees from the 60s and all the different types of questionnaires looking at, job stress, strain, demand, etc., personality types, etc. And they have done a very good job in trying to work out what the effect of stress is with weight and metabolic syndrome like heart disease, strokes, etc. I'll talk more about that in a moment, but one of the difficulties with your patients trying to lose weight with just dieting is that when you just try and eat less, what you see there is that the body has a weight regulatory mechanism in your hypothalamus, and it actually will reduce its metabolic rate when you try and eat less. Similarly, if you try and eat more, your body will try and expand that energy and increase its metabolic rate and even increase fidgeting. So it's really interesting phenomenon to actually explain to your patients, because it sort of tells you that a lot of patients that come in and talk to you about how I don't think that I'm really eating that much more than my sister or my friends, and yet I put on weight. They're not all lying. There's actually a basis to that. And yes, some of them maybe are eating in secret and not being conscious of their caloric intake, but most of them, I believe, are not actually lying. This is a study done by Dr. Priya Sumithran and the doyen of weight regulation in endocrinology, Professor Joe Proieto. And this basically shows you, on the x-axis is the time after eating, and on the y-axis is your hormone, be it the first panel is ghrelin, and ghrelin is the only hunger hormone that we know. And all the other three panels are satiety hormones. So amylin is going to come out as an obesity treatment hormone soon, but there's also PYY and CCK. And you can see that in black is where the hunger hormone was in the first panel, in panel A. And after 10 weeks of dieting, when the patients lose weight, the hunger hormone increases. And after 62 weeks, it doesn't return to baseline yet. Yeah, so your hunger hormone has increased after 62 weeks, and your satiety hormones in panel B, C, and D have dropped. In a sense, the body is trying to pull your weight back to where it was. Yeah, so it's a bit like stretching a rubber band. You know, everyone here, I'm sure, can stretch a rubber band, but how long can you hold that rubber band? That's the question. This is work from the Whitehall study. They found that it is not actually job demand or job stress that correlated with metabolic syndrome, but rather a phenomenon known as job strain. What is the difference? Job demand minus control is the strain. So if you're a high-powered CEO and you have a high demand, but you have a lot of control, your strain is low. But if you are someone that's low in the pecking order, you have not much control over your work, and therefore your strain would be high, and that correlates with metabolic syndrome. So one of my jobs is to help patients learn about control. How can they bring back control? Before the pandemic, I used to write letters, for example, for patients to be able to work from home, for example, just even 1 day a week for them to have a bit of control. But now after the pandemic, it took a pandemic for people to realize that we can actually trust our employees, not all, but most, but they would be able to deliver, in terms of productivity, and giving them that control is important. And this is just about one of the many social prescribing techniques that I use, and I can talk more about that if you have questions for me. The other thing that I think is really interesting for you to know is that stress correlates with weight. About 10% of people, virtually everyone, will lose weight to acute stress. So if you have someone really dear to you die, you'll lose weight, or you're nearly being run over by a truck, you won't feel like eating at all. Yeah, you'll feel sick. But for chronic stress, about 10% of people lose weight still. So if you have a high job demand, for example, about 10% will lose weight, as seen in the Whitehall study, but about 60% will actually put on weight. And this is the seminal study done by Appel et al. That showed that in the bar graph, you'll see that during a control period, which is those that have a high cortisol response to stress eat about the same as those that have a low cortisol response to stress. And the way they do this study is really interesting. They do what they call a Tria social stress test. So they make people talk in front of other people, like what I'm doing now. And the panel that listen are a bit derogatory. And then they put them in a room afterwards and don't tell the participants that the plate of food in the middle, they tell them, eat whatever you like. But they know exactly what's in that plate, yeah? But they're not told about that, and they monitor how much they eat. And so those people that have a high cortisol response, they don't eat dissimilarly to a low cortisol response during a control period, which is your bar graph there. But during a high stress period, you'll see that those that have a high cortisol response actually increase their food intake, and those that have a low cortisol response decrease food intake. Yeah? So there's a bi-directional relationship. So telling your patients about how to look at stress and how to modify stress-related eating, I think, is a really important part of long-term weight loss for those patients that you identify as having comfort food eating. And often you have to normalize the behavior for them to start talking about it. I'm going to move a bit quicker because I'm conscious of time, but on the y-axis, you'll see all the different things that can happen with progressive weight gain. So from diabetes, hypertension, dyslipidemia, etc. I won't go through all of it. But the good news is you don't need a lot of weight loss to actually see changes to these things. In fact, you can actually reverse diabetes, not just prevent diabetes, by losing sufficient amount of bad fat, I should say. And those are just some of the numbers that are available on the slides that you can take home. But that's a message that I often emphasize to patients, in that they have many goals as to why they want to lose weight. But one of the goals clinically that I mentioned to them is prevention of all these comorbidities, all these complications. I mean, I also honor their goals if they want to fit into their dress for their son's wedding that's coming up at the end of the year. Those are just as worthy a goal as all these. And I think they should all be congruent towards achieving a better lifestyle. So I'll go through a case study. So Sandra, she's a 48-year-old female with a BMI of 32. She's a working mom of 2 kids. She has been trying to lose weight with a PT and has low-carb meals. She has Hashimoto's thyroiditis on 100 micrograms of thyroxine, impaired fasting sugar, hyperlipidemia, and finds that she gets quite spread thin being a working mom in a stressful job. She is someone that I would talk about emotional eating, and because when I actually talk about stress to patients, I they can either tell you directly that after a long day at work, I come home and I'm going to prepare dinner. I don't have time yet, so I just pick whatever's in the pantry whilst I'm preparing meals for the kids. No one picks out a salad for stress eating. They usually pick out something calorically denser, and that is physiological. We see that in all mammalian species. So in terms of emotional eating, bringing about awareness as to what their patterns are. And so just talking about their patterns to them is a really central part of what I do. And then looking at the different supports and different modifications to not just what they're doing in terms of their eating patterns. Like if they eat well for lunch, then it's less likely that they will come home famished and needing to dive into something. But also if they dive into something, is the environment, do they have good things to dive into? Or are they just chips lying there? Or is it something healthier like nuts and cheese and, all that kind of stuff? So going through all that takes time. And unfortunately in medicine today, where some patients will go and see a different doctor every time, is not conducive towards this kind of long-term change. So these are things that you can't all do in one consult. You need to build a relationship with them over a long period of time. So I introduced not a diet, but more a high protein, high fiber, low carb way of eating. And the CSIRO has very good information on this. I did start her on metformin and liraglutide. We talked about mindfulness, stress reduction in daily activities, knowing the stressors before they occur. I engage a lot with motivational interviewing as a technique. And so many of the patients over time, they need to know about, things. They need to be interested in the things that will make a difference to them. And how do you build interest into what they're doing, what they're eating? So some of them want me to be prescriptive, and I try and switch them over from telling them what to eat to working out how to eat what they enjoy. That is high protein, high fiber, low carb. And that motivational interviewing technique allows you to do that. If you don't know much about it, the College of GPs has very good information on this. It basically respects the relationship between doctor and patient, but brings it more like this, so that you talk like you're talking to a friend almost. This is motivational interviewing, and one of the things about motivational interviewing that I will maybe touch on briefly is about relapse and learning about the different stages of change, but I don't think I have time to go through it. So we do a body composition analysis in my clinic. So I try to move away from just weight alone. And we like looking at not just the weight, which is your first panel. The second panel is muscle mass, and the third panel is % body fat. So you can see that she has lost from 79.5 kilos over 2 years gradually. So this is not a very sudden thing. They are eating in the way that is not a quick diet. Don't get me wrong, I do use VLEDs and all that kind of stuff for certain patients, but she wasn't interested in that because what she wanted was a long-term solution. And so she was able to gradually drop her weight down without compromising too much on the muscle mass because she was eating high protein, having good levels of exercise as well. And she lost the equivalent of 20% of weight. Now, with medication, you generally don't see that. Medication, usually you see 5 to 10% weight loss. This is more surgical level weight loss. And this is sustained over 2 years. And so for her to be able to do that, she's very pleased that she can now enjoy what it is that she eats rather than having a relationship with food that is sort of love-hate. And so I don't think that my talk is incongruent with the talk before, but that perhaps there should be more communication between the two, what seemingly are disparate philosophies, but essentially they're not. This is just to show you that if you look at the long-term data on, say, Saxenda, which is what my patient used, she was, you can see that this is a 3-year study. Your weight loss is about 7%. She did 20%. Yeah, and this is not, she's not a special case. I have patients that lose 30, 40%. So what I'm trying to emphasize here is that don't think of medication as just medication for weight loss and prescribe it. The ongoing lifestyle change is really important because that's where you get the biggest bang for buck when you combine them both. There are all these other medications currently available, and there's 3 more coming out, and I won't go through them. And the indication, as I said before, are very Anglo-centric. The BMI is 30 or more. If you have diabetes, obviously you can use it down to a BMI of 27. And this is just another case just to show you what can happen. So this is another patient, 30, BMI 42, over 2 years, drop BMI 41 to 32. And it is more, again, just increase incidental activity. I find that usually with weight loss initially, I don't encourage exercise because with BMIs of 41.4, you're just making yourself prone to injury. I think the biggest bang for buck is in encouraging good nutrition. And if they focus their energies more on that, that is where the weight loss happens first. But exercise will become important. Once they lose about 10-15% of their weight, we start to ramp up activity and exercise, and that is really important for weight maintenance. So that is one of the predictors of weight maintenance, is high level of physical activity. This is a study by Contrave, and I really commend them for doing this particular study because it's not just a randomized control trial. They did Contrave in a placebo arm versus an active treatment group in what they call the Core 1 study in your first graph. And you can see that the weight loss was between 1% for placebo and 8% for, or 1.8% for placebo and 8.1% for treatment arm. But they also did a study called BMOD, Behavioral Modification. And in that study, you can see their placebo arm was almost as good as their initial RCT with 8% and 7.3% in their placebo arm. But when you combine them both, you get a far better effect, 11.5 kilos. They also did it in diabetes, which is the third arm, but my aim of showing you this is that there are actually, a lot of people like saying pharma and, lifestyle are two sort of different camps, but no, they're not. As physicians, we can straddle them both. And I'm glad that pharma is actually listening and they're doing the studies that show the benefit of both as well. This is another patient, Laura. She sort of, you can see the dates underneath, this is over 3 years, and she loses quite a bit of weight on liraglutide, despite having irritable bowel syndrome and generalized anxiety. Her weight did go up over COVID, so this is pre-COVID stuff. Her weight went up to 110 or something during COVID lockdown, but I saw her again this week and she's back down to 96 now. Mental health is really important to address, and I feel that unless you actually tackle both simultaneously, neither will improve long term. Because weight actually has pro-inflammatory and cytokine changes, as many of you will know from the whole COVID. One of the biggest comorbidities to have for young people to die from COVID is metabolic syndrome. And, it has dysregulation of the immune system in terms of promoting cytokine storms. And that causes also changes to the brain, as does, psychological disturbances also causes changes to behavior that will help you with patient weight loss. So I think that both have to go hand in hand. And that's why I feel that weight loss is actually managed best, to be honest, not by endocrinologists, but by people that can do both, or endocrinologists that can do both. But I think generally those are GPs. One of the things to highlight from this slide is that medications should be discussed in terms of the psychotropics you pick. Try and have a chat to whoever, like I only get the difficult cases that GPs refer to me, but when I get them, they already are on certain psychotropics, so I never touch their psychotropics. So you have patients that you started them on, you know what sequence you have tried and all that. So generally, I would refer them back to you. or I would refer them back to their psychiatrist to work out whether there's a better psychotropic to choose. And I'm surprised often how quickly the psychiatrist will say, oh yeah, we can just change to this. It's like, well, you could have changed to that before and not promoted all that weight gain. So have a discussion with the psychiatrist if your patients are on psychotropics, like say Avanza or any of the, antipsychotics. This is from Medicine Today, looking at the complexity of weight and looking at not just the tip of the iceberg, which is activity, nutrition, stress, but actually underlying all that is also sleep. If you don't sleep well or you do night shift, it's really hard to lose weight. If you are suffering from, difficulties in your life, in relationships, and you're not going to find weight loss a priority, or even dealing with your medical condition. Why is obesity rate so much higher in Pakenham than in South Melbourne? Inner city versus outer suburb, rural versus, metropolitan. These are all things that contribute to the epidemic that we see. Social prescribing is something that I try to use to help correct some of those inequities. And you can do very light sort of social prescribing, like signposting, and I'm happy to talk to you outside after my talk on what we're doing currently. But in the UK, they do this a lot better with engaging a link worker, which the NHS funds, and they actually promote patients going through them to work out what sort of activities and supports that they actually need. And I hope one day this country will see the same. But currently with the signposting, like I said to you before about writing a letter, a simple letter to an employer, or even having my diabetes alert dog in the room stimulate discussion around having a pet, for example, and that is quite useful as well. So for those of you who read The Republic, there is a very nice article on that, on mental health, just this issue. These are all little things, but they make a big difference. The general things that you can actually look at in terms of social prescribing are ways to overcome social isolation and loneliness, meaninglessness or lack of structure. So a lot of people, they retire and they don't know what to do and they flounder without any structure. Having even just one thing a week structures not just the day, but the week as well. And some of the things that we have in currently in small rural areas are like men's sheds. We have a garden to plate program. And recently we started doing a program called Weight Off Your Shoulders in Clunes, which is a little town just outside Ballarat. And in this particular program, we basically looked at, think of it as being metabolic syndrome in a sort of Alcoholics Anonymous style program. And I engaged with the local GP practice in Creswick, Kerry, and she basically ran the program. And you can actually bill Medicare for these medical appointments. And it's actually well studied, and I'm not going to go through that, and you can look it up yourself in the journal that was referenced. My last patient that I want to talk to you about is a telehealth patient that I did. Basically, she's someone that has really tried to lose weight from a young age and was progressively despondent to the point of having tried back in the day when they had Reductil. She was someone that was very versed with all the different diets, Weight Watchers, etc. And she started developing rheumatoid arthritis to the point of needing wheelchair access, and they were thinking of even selling their house in Gisborne. And she was placed on intermittent courses of steroids by her rheumatologist, and that didn't help with her weight. She was on biologics, methotrexate and Plaquenil. And her dietary history showed that she was actually quite good in terms of what she was eating. And this is where I come back to again, is like, don't disbelieve your patients. A lot of them actually genuinely do try and are not actually binging. Like I can eat a chocolate bar and no one will sort of say, aha, there you go, that's why your weight's high, you know. But these patients, they put a chocolate bar in their trolley and they just feel awful. People just give them glances and things that's sort of really disproportionate to what the actual sin is. So we looked at stressors leading to comfort food eating, activity levels, which she couldn't really do much on because she was just very immobile. She did say that she liked gardening, and in the telehealth session, I usually have the GP sitting next to the patient and the husband was sitting behind her, and I could see that the husband was quite keen to help her and listening quite intently. And she initially did quite well moving on from a wheelchair to walking stick. And I did do some investigation to see that she was pre-diabetic. We trialed her on Saxenda or liraglutide. We didn't really need much because she actually got sick on higher doses. So a lot of people complain that, you know, Saxenda is too expensive, it's $400 a month, but at 0.6 milligrams daily, it's only $70 a month really. We discussed well-being diet rather than actually restrictive eating. And she actually liked gardening. And I said to her, well, why don't you look at doing more gardening as your activity? So don't worry about exercise. And we reviewed her level of activity quite regularly. Even just talking to your patients about it helps them, encourages them to actually do it rather than actually just sending it off to an exercise physiologist, you know. I think this is social prescribing, I think. And the husband was so keen to help her, he actually built vegetable boxes and things that allowed her to garden without having to bend down. And over time, she loses weight quite gently, so 1 to 3 kilos every month. And in 6 months, she lost 16.4% of her weight on a tiny dose of Saxenda. And she reverses her prediabetes. And the rheumatologist was impressed that her mobility was improving and stopped her biologic. And she most recently had also been able to drive again. And she's now gone back to working, she fits bras for women that have had breast cancer. And so she's gone back to doing that. This is her vegetable box on one side. And also, this is obviously taken in summer. So broad beans in the boxes. You can see the tomato plants growing out of the plastic thing. I'm not sure if I would like that, but anyway, it's easy access for her. But she loves it. She just goes out there all the time. And no doubt it also did wonders for her, you know, vitamin D and her psychological well-being as well. So by one social script, I have improved a few things for her. And I don't know many medications that can do that. If you're interested in social prescribing, that's a reference for you. And Stuart Smith is a psychiatrist in the UK. She writes about the power of horticultural therapy. I thoroughly recommend reading her book. I listened to her ebook because I don't have time to read anymore. And her husband is actually a really famous landscape designer in the UK. In fact, I'd say the top designer in the world today. So I don't have time to go through this in any detail, but these are my conclusions. It surprises people when I say to them that nutrition and activity is not the foundation of good weight loss. It's actually psychosocial well-being, and how it translates to your practice. It doesn't just translate to how you talk to your patients, what you suggest to your patients, but the structure of your practice as well. It should permeate that way. And I think the government should also look at Medicare systems that promote that as well. And it should permeate into every aspect of care. And what I generally, this is my gold slide, okay? I always come back to this with my patients. This is actually mounted with all the body compositions that you see of patients, de-identified, of course, and showing patients that this is what you need to do long-term if you're gonna do this forever. Because you know that weight regain is what the hypothalamus is going to bring. If you don't do this forever, if it's not sustainable, you will not be able to keep your weight down. So I'll finish on that slide. Thank you.
so much. That was some lovely presentation that I think perhaps heralds a public health new epidemic that's coming our way, isn't there, really?
There is.
You described that multifactorial relationship between culture, endocrinology, epigenetics, stress, mental health issues, and we've just been through a pandemic and a social crisis that's created this these social distance restrictions and perhaps a loss of many of those adapting coping strategies, although many of us now have lovely gardens, granted. But you describe, so there's the etiology, but the adaptation, I guess, is across those, as you say, those relationships, rebuilding those relationships. I think there's a lot of work for us to do in healthcare, isn't there,
There is.
coming years?
And I think also learning to gradually integrate it into our patients' lives is what is the most rewarding in my job, in that it no longer becomes just another patient, but it's like seeing another friend come back and saying what they've done, why their weight has gone back up, what is happening in their lives. That I think gives longevity to the clinicians, because otherwise weight management becomes quite a soul destroying exercise for the clinician and the patient. And unless you actually tap into that deeper dimension, you will actually find yourself burn out.
And I think the pandemic's created those chances for people to reflect upon maybe what's gone wrong, but how they're how they're recovering now in this time. It's created those interesting conversations where people are receiving that feedback, aren't they?
Correct, yes. And I think that in a way the pandemic, has a silver lining in that it really actually makes people realize what these psychosocial implications and the impact is, because perhaps before that we weren't paying as much attention. And I just hope we don't just go back to normal and then just forget about it, and then this pandemic continues to grow. This obesity issue is so big, pardon the pun, that in Australia alone, if you look at all the comorbidities and all the time off work, etc., it's already costing $90 billion a year. You have to modify all the equipment in your hospitals. You have to, I hear anaesthetists telling me how hard it is to operate with these patients, why wait and wait to do something to change your Medicare system to allow doctors to treat this effectively? Why wait for worse to happen? I liken it to climate change. They're growing problems. It's not happening immediately like COVID, and everyone suddenly realizes there's an urgency. No, this is a problem that we are waiting and waiting for it to get worse and worse until Lismore floods, and then suddenly everyone goes, "Oh, we need to do something," and then it will go away and people become quiet and quiescent again.
Well, thanks for presenting, I think, what's something that is a model of care that we can incorporate in primary care, because we do work across lifestyle, medication, a lot of what you described we could do in social prescribing. I think it's going to be interesting to think about who are those linkage workers, and I'm immediately thinking about not only GPs but nurse practitioners and practice nurses, and how can we work within that system to create social prescribing.
To help. Yes.
Could you describe social prescribing, because we don't use this term very often in Australia, but just a quick definition for people?
Yeah, so the definition was in one of the slides, and essentially it's recommending psychosocial change for patients in a prescriptive fashion, whereby the patients can comfortably take them on. So you don't want to go from, someone that can't even leave the house to telling them to join a gardening group, that's just not going to work. So social prescribing essentially is prescribing a psychosocial change. And I've given you some examples of it. If you're interested, the neighborhood houses, this is a bit of promotion for them, in the Goldfields area, which is where I'm from. They are engaging doctors that want to be involved in this. So please get in touch with the neighborhood houses. You can just look up my website. My website is parksidespecialists.com.au. If you Google Kevin Lee at Parkside Specialists, you'll see a video about social prescribing up there. But you can also look at our Grampians Weight Specialist website, which is where we try and help doctors that want to be mentored and learn about this kind of an approach. and also who want to set up a clinic that needs a bit of support to do so, we can also engage with you as well. So get in touch in
Great,
those
thanks.
3 ways.
And I think that the relationship with motivational interviewing is, as you're describing social prescribing, I'm thinking that motivational interviewing has some interesting tools, doesn't it really?
It does, yeah.
I think our Westvic YouTube Learn has some excellent short clips on motivational interviewing, and we might try to find out whether there's also some courses that people might participate in if they're interested, because I know that you mentioned the
The
importance
College
of
of
that.
GPs has the courses as well.
Yeah, great.
they
Okay,
do, yeah.
thanks. Now we do have some questions, and I've just got a couple of minutes, but most of the questions do actually relate to that tip of the triangle with medications, and in no particular order because no one's upvoted, so I don't know what your favourite question is. So do remember to upvote if you'd like to prioritise questions. So I'm just going to go rapid fire if that's okay. You mentioned using liraglutide, otherwise Savada, Saxenda, to help with binge eating disorder. Are there other approved medications such as I know we did eventually have a slide on the medication, so I'll just cap off on this. Fluoxetine, topiramate, lisdexamfetamine that you consider?
Yeah, topiramate is one I would consider amongst all those, and there's a different dosing regime though, and I don't have time to go through.
No, that's okay, thanks. Your thoughts on Ozempic? Again, this is another...
Yeah,
Sorry?
Ozempic.
Yeah, I can't get it.
Ozempic is a really they have compared it head-to-head with Saxenda, and it does come out ahead, and it is more effective. It's just once a week, but you can't get it, as the delegate rightly pointed out, because it just suddenly took off in terms of demand and the supply cannot meet it. And so the TGA has mandated that we first supply it to people with diabetes. So if you're trying to prevent diabetes using Ozempic, sorry, you miss out. We give it to people that already have diabetes.
Once that horse is bolted. For patients who are enjoying a very low calorie diet with Optifast 2 times a day as maintenance, can they stay on this long term?
They can, but Optifast long-term is quite unpalatable. And I find that if you can go beyond 3 months, you're already doing very well as a patient. My record patient is 2 years, but it's really useful for patients that are very busy and don't have time to, like my first case with the working mum, she did every now and then use Optifast to replace her lunch, for example, and they are micronutritionally replete. So it is possible to use, but there's a way to use it safely. So I'd recommend that you learn about that.
Great, thanks. And then one final reflection was the cost of non-PBS medication for extended periods of time, and particularly this relationship with lower socioeconomic groups. Your thoughts? My
remark is quite scathing, I must say, of this, in that if you are well off, you will do well with the medication. And it's not very expensive. So Ozempic, for example, it's $140 at most a month, yeah? And for most of my patients in inner Melbourne, that is nothing to them. But if you are not well off and you cannot afford it, sorry, not for you, then the government won't reimburse any of these medications for you, unless you are DVA, of course, and then I'll write a letter for you. But otherwise, sorry, it's not for you.
Thank you. Well, there's certainly a lot for us to think about, because I think we've got a public health problem already, and I think it does seem like it's heralding that it's only going to get worse. Yeah, but thank you so much for a very elegant presentation. So thank you. Please join me in thanking Dr. Kevin Lee. We've now got a 40-minute break, so please take time to stretch your legs, grab a coffee, bathroom break, and something to eat. We'll be